Okay, well, I think we'll kick off as the time has now gone 2:30, and welcome everybody to the APPG on Global Health's report launch on new directions for the mental health workforce globally. I'm sure more people will be joining us during the course of the meeting, but we have recently, as an all-party parliamentary group, been working with Implemental and taking evidence about the shape and form of the global mental health workforce and making recommendations in the report that will be launched today to government and to other policymakers both in the UK and overseas about how the provision of mental health services through the workforce in particular can be improved. I'm going to in a moment hand over to Jonathan Rolfe of Implemental, who will give us a few moments about the headlines from the report, and then we have a panel discussion to follow that with a number of very distinguished and well-known global mental health experts before an opportunity for some questions and answers, and then some concluding remarks from Lord Crisp, who is the co-chair of the all-party parliamentary group. Now, just a few pointers. If everyone can, if you missed Nicole's very brief opening comments, if you could please mute your microphones, and questions please by raising hands after the panel discussion. I'm sure some of you may want to make some points as well, but if you can raise hands, and then through me we'll take questions from the audience after the panel have had their chance to respond to the report. Can I first of all just put on record my thanks to Implemental and the team there, as well as to a number of my parliamentary colleagues for the work that's gone into putting this report together. It's been the culmination of many months of work, and we're very grateful to everyone who's come to give us both their views through our witness sessions and also provided written evidence which has helped to inform our view and recommendations to both UK government and policymakers both here and overseas. So without wishing to delay matters any further, if I hand over to now to Jonathan Rolfe of Implemental, who will take us through the headline recommendations of the report. And thank you, Jonathan, for all that you and the team have done in putting this together for us.
Thanks, Dan. I'd like to start by thanking you, Dan, and Lord Nigel Crisp, the co-chairs of the APPG, for inviting Implemental to be the research partner for this important report, and for all your support during the development of the report. I'd also like to thank all of the stakeholders and witnesses who contributed to the report. Their input has been invaluable, and we hope that this report will have a real impact in shaping the future direction of the mental health workforce. Given the challenges and impact of COVID-19, there's a growing need and demand for mental health services. When we consider that 1 in 4 of us will experience a mental health problem within our lifetime, and that 1 in 7 people are currently living with a mental health or substance misuse problem, it highlights the scale of the issue. However, in low resource settings, the treatment gap can be as big as 90%. The report includes a case study from Peru, where only 12.8% of people were receiving the treatment that they needed, and how this system was reformed. Mental health has received many years of underinvestment. Despite the high demand for mental health services, only about 1% of the world's health workforce is providing mental health services. In the 2011 WHO Mental Health Atlas, it was estimated a shortage of 1.2 million mental health workers, a figure that I'm sure is now significantly higher. As an example, in some low resource settings, there are only about 2 mental health workers for every 1,000 people. And to further compound the problem, much of the workforce tends to be located in large urban areas, meaning people living in rural areas are unable to access appropriate services or need to travel long distances to do so. In addition to the humanistic argument that more needs to be done internationally to improve mental health, there's a strong economic argument for the case of greater investments by government. It is estimated that the cost to the global economy of poor mental health is 16.4 trillion US dollars. Now that's a figure I can't even visualize in my mind. There's also been research that shows the return on investment is 3 to 5 US dollars for every dollar spent on mental health. So there's a huge opportunity and return on investment. We received strong messages from stakeholders and witnesses that radical change is needed and that we need to take a more innovative approach to workforce, including building skills and capacity in primary care, embracing new roles within the workforce, such as peer workers and experts by experience. We need to find new ways of working with people to ensure that people can access services in convenient locations by wrapping services around people and making them convenient to access, fighting stigma and discrimination wherever we find it. We must enable the workforce to become agents of change, leading and facilitating new innovative ways of working. We need to change the narrative to talk about health creation and encourage schools, universities, workplaces and wider society to play their role in creating healthy environments that promote well-being. The report outlines a set of holistic recommendations to a broad range of stakeholders. We ask every sector of society to fight mental ill health and to build health-creating societies. This transformation requires the existing mental health workforce to become agents of change and enablers. The report calls on governments to develop long-term investment plans for mental health and to create parity of esteem and equality between physical and mental health. We need to adopt a whole-body approach to healthcare. We ask governments to also ensure responsible recruitment and support the development of services in lower resource settings. We ask service providers, health professionals and professional bodies to strengthen existing roles and to embrace new roles such as peer workers, experts by experience, creating team approaches to deliver holistic and innovative service models. We spend about 1/3 of our time at work. That's over half of our waking hours, so workplaces have a crucial role to play. The report speaks to organisations, asking them to create mentally healthy workplaces that offer rewarding and healthy work opportunities that do not discriminate and give permission for staff to talk openly about their mental health and well-being without fear of stigma or discrimination. To educate staff by inviting people with lived experience to share their stories with employees. Health educators also have an important role to play in ensuring that substantial mental health content is included within the curricula and inviting people with lived experience to share their stories. Equip professionals to become agents for change within the communities that they work. Health educators should also support the continuous development of both specialist and non-specialist staff. Adopt the use of digital technology and platforms in the delivery of programs and as a way of providing remote supervision in hard-to-reach locations, and also for enabling international collaborations. I've shared with you a very brief summary of the report highlights. The report argues that radical change is needed, and I will leave you with this quote that resonates for me from Professor Dinesh Bugra. Mental health is too important to be left to the specialist. It is everyone's business. I think that's a really important piece of feedback to us all. So I'd like to hand back to Dan now, but I hope that gives you a bit of an overview and a flavour for what's in the report.
Thank you, Jonathan. And we'll come to some questions shortly. But just before that, we're going to have a contribution from our panel, many of whom have been key contributors to the report that you see today, just to build upon what Jonathan has said and talk about the need to reshape the global mental health workforce. So we have on the panel today for joining us the discussion, Dr. Florence Bangana. Sarah Klein, I believe, is now not with us, but maybe joining us later. Dr. Fahmi Hanna and Professor Dinesh Bugra. Each of them, I'm sure, will tell you a little bit of their own backgrounds when they speak. But to tell us a bit more about key recommendations in the report and their views on how we can deliver change. And I will ask each of the panelists to make a contribution. So if we can start then with Dr. Florence Bangana, please.
Thank you very much. Thank you very much. I thought I had muted myself. Thank you. It's a huge pleasure to be here today. I want to thank very much the all-party parliamentary group that did this work and developed this report, which is going to be useful for very many different parts of the world, not just the UK. For me, what comes out most from the report is the recommendations made touch upon not just the medical field. They go outside of the medical field as well. We tend to sometimes prepare reports as in the health sector, focusing only on the health sector, but this report clearly recognizes that mental health cannot be fully achieved for everyone unless we move outside of the health sector and work with all the other sectors, including education, where most of our young people spend their time. Maybe 9 months out of the 12 are spent in schools, and therefore it's important for us to ensure that their mental health issues are addressed, especially very early on. The other one mentioned is, of course, in the workplace. You finish schooling and you're in the workplace. And so that's another place where one could get, leverage mental health services. What is also important is that it has to be the governments that prioritize mental health and mental health workforce, because however much anybody else does, our development partners do play a key role. That is really important. But as long as the governments themselves have not prioritized mental health, it's only so far that we can take it. So if we get projects, for instance, that come in and work for a specific period of time, and then the time is over and they depart, then those healthcare workers who had been employed by the project would probably discontinue the work once the project is over. And therefore, we want that whatever is developed is systematized, and I think it runs through this report, that it has to be prioritized by governments. Governments have to take a long-term view of mental health and ensure that it's integrated into their long-term planning. I'll stop there for now. Thank you.
Thank you very much. And now Dr. Fahmi Hanna.
And thank you so much. And I'd like really to thank the organizers for this privilege to be with you on the launching today. My name is Fahmi Hanna, and I work at the WHO Department of Mental Health and Substance Use at WHO headquarters in Geneva. And it's really a pleasure and privilege to join you today in the launch event of the important report, New Directions of Mental Health Workforce Globally. WHO welcomes the launch of the report, and we acknowledge the global need for immediate investment through whole of government approach, as stated in the report, in a coordinated integration of mental health intervention into all sectors' work. Colleagues, a paradigm shift is required, especially in how all development and humanitarian actors view this area of work. Mental health and psychosocial support should not be considered a complementary add-on to our programs, but as an integral component, a basic need and a human right. To be better prepared for emergencies, we need to invest in human resources. While the emergencies create significant challenges for health planners, they also present opportunities to reorganize services and train workers to better manage mental health needs. The best results we saw at WHO at country level following major emergencies such as COVID-19 and other public health and humanitarian emergencies are when the mental health system considered and strengthened as a whole, and when human resource capacity is built, repurposed through task sharing of non-specialized professionals, as well stated in the report. To build back better after crisis and to build better before crisis, investment in people and service reorganization should usually overweight investment only in construction or refurbishing of buildings. Colleagues, WHO has emphasized for decades, there is no health without mental health. In May this year, at the World Health Assembly, at our governing body in WHO, the 194 member states of the organization reaffirmed that there is no emergency preparedness and response without mental health. The updated Mental Health Action Plan adopted until 2030 include a set of implementation options and monitoring indicators, including reporting by all countries of the world every 2 years on mental health preparedness functionality. WHO appreciates the recommendation in the report launched today to reverse the cut in the development assistance. This cut has negatively affected a number of ongoing MHPSS initiatives for humanitarian settings, such as the development of minimum service package, and wonderful to see a recommendation for its reverse by the authors of the report. We really appreciate this extremely important point in the report. A few years back, even before COVID-19, a World Bank WHO investment case analysis projected that the global price of lost production due to common mental disorders would amount to more than 10 billion days of lost work annually. This is equivalent to $1 trillion per year. We cannot afford not to invest in this area, as the cost of not investment is too high for children, families, emergency responders, and economists. I use this opportunity, colleagues, to acknowledge and thank the APPG for this important report, and WHO. We are committed to work together with partners to strengthen the multi-sectoral mental health and psychosocial support as an integral component of universal health coverage. Thank you so much for the opportunity to be with you today.
Thank you. And now to Professor Bugra.
Thanks very much, Dan. Thank you, and thank Nigel for involving me in this. Really, I see this report as looking at something which is of vital importance, but from outside the box. What is it that we ought to be doing? And one of the big challenges really is that if we look at mental health in the form of a pyramid, right at the bottom is the self-care. How do we look after our own mental health and of those who are around us in our family, our friends, our peers? And equally, then you move up to the community care, and how does community care develop, and how does the community respond to people's needs? And then going up the pyramid is the primary care, and then secondary care. And within secondary care, again, there are tiers where schizophrenia and severe mental illness reach the top of the pyramid, and you've got other conditions. So one of the big challenges really is that how do you create a workforce which can deal with all of those? And it's not impossible. I mean, I think there are 3 or 4 lessons that we have to look at. I mean, first and foremost, through my role as past president of the World Psychiatric Association, we looked at wonderful examples of community engagement and working with different communities, and different communities having different ways of dealing with distress and up to severe mental illness, use of volunteers, use of community leaders, use of teachers, use of religious leaders. So there's a whole host of human capital which is out there that we don't use. And I think we need to be thinking about how we're going to do that. And part of that argument is that, when COVID hit this country in, first lockdown March, and when the Prime Minister went and sort of said, we need 250 volunteers, within a few days, there were 250,000, not 250. But within a few days, we had 750,000 volunteers. So there is human capital. So how do we use it? How do we work with them? And it's not that, psychiatrists or psychologists or nurses have all the answers. Each culture has different ways of looking at health, well-being, mental health, mental well-being. And each culture has a specific role attributed to relationships, to sociocentrisms, to religion, to spirituality. So how do we channel those? How do we work with those? And it is partly looking at those examples of good practice in different countries. Volunteers have been used in some countries. Teachers have been used to identify people with serious mental illness, and Professor Jenkins was very heavily involved in developing that. And in other countries, there are, we've got Didier from Cameroon, and he can tell us a bit more about aunties and what aunties do. And Jonathan sort of mentioned the point about mental health gap. Even in this country, if you look at substance misuse, for example, the 70% treatment gap. So I don't think we should be complacent about it. And I think we don't have the answers. The lesson really is, in a truly international way, we need to learn from each other. We need to learn how we can do things differently, how we can do things better, how we can create partnerships and dialogue. And to that end, I think this report is a pivotal point. And I'm really grateful to All Party Parliamentary Group to pull this report together and to try and share examples of good practice, to share lessons, how not to do things and how to do things. And, everything, I mean, it's a global audience, and let me sort of emphasize that the developed countries do not have all the answers. We need to be thinking in a different way. We need to be looking at different classifications. We need to be looking at different strategies of pathways into care and interventions. And Florence sort of raised the question of education, absolutely vital. We need to catch people early. 75% of psychiatric disorders start in the adulthood, start below the age of 24, 50% below the age of 15. So we need to get in there. But let's not forget employment, as Florence mentioned, but also housing and societal support, and working with different cultures and different societies to try and engage people. The survey we did for the WPA showed that 40% of the countries allow people with serious mental illness to have rights to vote, right to marry, right to have a will, and right to employment. That needs to change. So you need both top-down and bottom-up approaches so that they can meet in the middle and really create a new world for people with mental illnesses. And once again, thank you very much for inviting me. I'm delighted to be here and happy to take questions or comments. Thank you.
Great, thank you, Professor Bugra. So just if people wish to ask questions, I'm sure we've now got quite a large collection of people at the meeting. So if people wish to ask questions, they want to raise their hands, and I will then through me we can then put those to the panel. But just one question I just wanted to raise, picking up on the point that Dinesh just made, that we have in the report, is this I suppose pyramid of care, from people with with all the way to people with very severe chronic and enduring mental ill health, or more acute, there's the schizophrenias, and we see and one thing the report picks up on is that in some countries there is a focus on with a lot of the resources put into in-hospital or institutionalized care, and the need to deliver more care in the community. And I just wondered, given what is obviously a resource-constrained environment in which many low middle-income countries work in, how we can help to begin the process of making that transition.
You're asking me?
If that's the first.
I'm sure, Florence would like to come in, and Fahmi would as well. But I think there's sort of several strands to the argument. I mean, Rachel Jenkins' work has shown that for every dollar you invest in public mental health, you save $6. So there's an economic argument. Then there is the argument in engaging with the community, because we focus, sometimes there's a tendency to focus either on severe mental illness or on common mental disorders. We should not be. It's mental illnesses. It's not mental health issues. It's not mental health concerns. And each individual who's suffering, the people around them who are suffering as well, their families, their carers, their community. So religious leaders, and there have been wonderful examples where religious leaders look after people with some common mental disorders, but they'll quite clearly have told me that they would not touch substance misuse. We need to be looking at what are the strengths of a particular culture and how do we build on them, rather than saying this is the model and it will work. Asylums are easy because you can invest in them and you can lock people up and say, out of sight, out of mind. But economic argument and the cultural arguments are much more powerful, and I think we need to push that.
Thank you. Florence, do you want to come in on that?
Yes, I'd like to come in, please. It's an important question and not an easy one, because for us in the African region, less than $1, I believe it is less than $1, or is it less than 10 cents, is invested in mental health. And of this, 80 to 90% goes to institutions. So what we must recognize is the institutions right now are very poorly funded. And that's why we have huge issues of quality of care. At the same time, they are necessary. I believe we do need some kind of admission, some place where admission would take place. But when we talk about access, providing access to quality services, it makes sense for us to move to the community and build those services there and at primary healthcare level as well, which means that some of that very little budget would somehow have to shift, because very often our governments are not willing to put in additional resources for mental health. So this is a very, very difficult conversation we often have to have with those who run the institutions, often the psychiatrists, because it's as if we are pulling away from the very little resources that they have. But what we are doing with the WHO Director Special Initiative for Mental Health is to see how we can actually operationalize the building up of community mental health services and also at primary health care. At least for us in Zimbabwe, which is the special initiative country, this is what we are doing. We're trying to see what are those community level interventions we could scale up, one of them being the friendship bench. It's going to be scaled up, but we're also going to, of course, do some mental health gap training for the primary healthcare levels, because you can't build one level and then miss out another. We need continuous care from the community to the primary care level, and then secondary, and then tertiary. But for now, we are going to work on seeing how to build up the community care services, primary care services, and to do it in a cost-effective way that we would then be able to replicate in other countries in the region. Thank you.
Great, thank you. And Fahmi.
And thank you so much. I think it's a great question, and as rightly said by Florence, 80% of the budget available in low and middle income settings end up in psychiatric hospital, and this 80% actually come from very small pool of funds. So still not much, but come in places where they are usually set in capitals and not covering a wide range of cities. The key approach that WHO would recommend is to scale up mental health services in general healthcare, in primary and secondary care facilities. Tools for doing task sharing are recommended in the report we are launching launching today and is recommended through WHO interventions such as image gap for building capacity of non-specialized health worker to manage priority set of mental health condition. These tools do work, are effective. For example, the UK has funded since 2014 a scale-up program for mental health in Syria in areas affected by the ongoing conflict. Before the conflict in Syria, classically mental health was only in Damascus and in Aleppo, in the two largest cities, and only in asylums, only in psychiatric hospitals. Because of the funds of UK and during the armed conflict in Syria, I'm sharing with you here a link. If you can go to page 2 of that link, actually you can see the spread of current primary healthcare facilities in Syria during the conflict or despite of the conflict, moved from only 2 cities, Damascus and Aleppo, to now covered in 12 different cities around Syria, and also in 140 primary healthcare facilities compared to only 2 psychiatric hospitals before the war. So it can work in Syria in very difficult circumstances. It can work elsewhere and do work in so many countries, using emergencies such as COVID-19, following emergency as an opportunity to repurpose and reshape through task sharing the work of general healthcare professionals. The link I just shared, if you go to page 2, you can see the primary healthcare facilities currently in Syria covered through such interventions. Thank you.
Great. Thank you. We've now, I think Sarah Klein has now been able to join us. So welcome, Sarah. Is there anything you wanted to add at this point? I mean, as you now joined us, what you wanted to add? We've heard from the rest of the panel and had some an opening question that I said. Anything you wanted to add to your thoughts on the report and the direction of travel?
Thank you, Dan, and thank you very much to you and Nigel for inviting me and to the panel. I was able to join a bit early, so I heard most of the panel speak, which was great, and I recognise quite a number of people in the audience as well, so that's lovely to be amongst friends. I think just to reiterate how important the report is and the recommendations, and particularly the role that the parliamentarians can make in the case for change and reform on mental health. I think that's been covered a little bit, but I wanted to reiterate that point here. I was speaking to the Secretary General's office last week about mental health. We do quite a lot of advocacy with them, and we were agreeing that actually the case for and change on mental health is being increasingly made globally by UN agencies, by other leaders, but the action needs to happen on the ground, and that's where the work that Eleni and others have done to develop the new mental health policy in Ethiopia that was launched last week, and Eleni's here. The work that's happening in other countries, the Mental Health Act that happened in India not so long ago, all those things are critically important because that's where some of the reforms that you're talking about really happen. And that's where parliamentarians and legislation reform is necessary. So, for example, there are a number of countries where suicide is still criminalized, and that impacts people's ability to come forth and seek support. And a number of former Commonwealth countries are part of amongst those, including the Bahamas, Kenya, Malawi, and Nigeria. So there are roles for parliamentarians to play in talking to their parliamentarians in other countries, their fellow parliamentarians, and there's a role for the British government to play on mental health that Fahmi and others have mentioned. And we've had very positive conversations with FCDO about the development of their policies on mental health, notwithstanding the cuts in aid which have impacted those. But there's also the role of the UK, which I think this APPG and others can help influence in terms of their leadership at the Global Fund and also with the World Bank, where there's point about integrating mental health with physical health, which is something that Fahmi's talked about and with UHC is so important. So I think just to reiterate how important that report is, not just for all of us here, for whom it's very welcome, but also how it can be used as a tool for the future to achieve change. Thank you.
Thank you. I saw a hand who's going to go down from Rachel Jenkins. Has that now gone down, or I think it may well have done.
Thank you, Dan. Sorry.
No, we actually go for it by all means. So address the panel.
Sorry, Dan. Can you hear me?
Yes, can hear you.
Oh, right, sorry. Yes, I was busy
answer.
typing because I couldn't see my hand up, so I thought it hadn't gone up. It was really just to come in on this decentralisation issue. And first of all, to say thank you and for inviting me, and I look forward to reading the report. In relation to decentralisation, I think we'll be helped by the move in a number of countries to decentralise their administrative structures. And so policies, plans and the budgets are going locally. So for example, in Kenya, there's now 30 counties and they each have their own budget. The National Ministry of Health does not control the mental health budget anymore. It's each local county that does. So the challenge for us is to make sure that the people who will be on those planning committees, so it might, if you're lucky, be a psychiatrist, often it'll be a psychiatric nurse, they'll have to be well educated to argue for the intersectoral and biopsychosocial vision that we want. And that everybody's talking about and really stems from Alma Ata. So I think it comes back to training of our health staff and others. So to make sure that when they're in important administrative positions, they're arguing for the right things. So I think we have to go back and take a look at all our curricula to make sure that the new students coming through, wherever they're going to go, have the vision. And I think at the moment, our training is still highly orientated towards specialist clinical work, and it's not orientated to the wider vision that people will need if we want these local plans to achieve what we want. So I think the opportunities are there, but we need well-educated people to grasp the opportunity, to fight their way into the local planning committees and transmit the vision.
Thank you. That's very helpful. I've now got a question or a comment from Masembe Nakata.
Hi, good afternoon. Thank you. My name is William Masembe Nkata. I'm originally from Uganda. I just want to say initially a vote of thanks to the initiation by the group in UK. It's not the first time. I remember of the Basic Needs Initiative. I don't know where that ended up, but it was a very good approach in terms of decentralizing mental health and taking it away from specialism as the only contributors to mental health. My question is, for people like me and many others who are soon retiring from NHS and who will be willing to engage with this new initiative and paradigm, how do we get into that to become trainers, or is the initiative addressing that? But also what I wanted to respond to the issue of remote supervision. I was involved in a case in an initiative which introduced mental health awareness and early intervention to the Ugandan Defense Forces in 2014 and 15. And we employed, one of the ideas was the first aid, mental health, and the use of the global mental assessment tool in being used to remote serving soldiers to be able to access specialist advice. So I think there's a lot which has been done. A lot needs to be centralized and more organized, as the initiative is suggesting. I think that's what the issue of mental health, too important that it has to be a business for everybody. I'm very grateful that this time the issue of service users as experts is one of the identified approaches which will meet this paradigm change. Thank you.
Thank you. I don't know if any of our panel members have any further thoughts or comments. Do any of our panel want to say anything else at all? Okay, right, well, can I thank very much all of our panel members, Florence, Sarah, Amy and Dinesh for their contributions to the report more generally, and indeed to all of our other contributors to the report, both the written evidence and the oral contributions that were made in our witness hearings or through interviews. I think we've come forward with something, a piece of work that will be very helpful in informing the UK government, but more generally will be useful for policymakers generally in a general way internationally. So I think as we've now come to the end of the formal presentation of the report, I'm going to pass over now to my co-chair of the All-Party Parliamentary Group, Lord Crisp, who will make some concluding remarks to our meeting.
Thank you very much indeed, Dan. Actually, before I say something, because I'm only going to take about 5 minutes, I noticed there's one more hand up. Should we see if Bridget would like to come in, who's got her hand up, and just take one final question, as it's the last remaining hand?
Yes, we can do. Yes, absolutely. Bridget, do you want to give your question?
Yes, thank you very much. Good afternoon, everyone. My name is Bridget, and I'm a psychiatric nurse in the UK, currently in Kenya, raising mental health awareness. This is something we've been doing. We have been a group of professionals from UK raising mental health awareness. Unfortunately, it has become a challenge for us to reach the authorities. So I just heard, I think it's Rachel Jenkins, saying they are going to recruit professionals who are knowledgeable in mental health. So I probably wanted to ask, what is the criteria that is going to be used for us who are out here, and because of being out of the country, we may not have the opportunity to be recruited as one, as people who are desirable to be in the community. We are doing this in the community. We are supporting teams. Sadly, we are not recognized by the government. Maybe it's because we are not able to reach out. So with the influence of this group, how can we possibly be included those who are working in the country? At least we can give them the knowledge we have gathered over the years in the UK to support our community, our patients to be in the community safe and maintaining their mental well-being. Thank you. And I apologize, I was a bit late. It took me long to log in. I struggled to log, but thank you very much for having me as late as it is. Thank you.
No, well, thank you for joining us, and thank you to everybody who's joined us. We've had an increasing number of participants throughout a meeting, which is unusual in that normally as meetings go on, people drop out. So I think it makes the point about how important all of us feel this agenda is, and also that I think it's a credit as well to the quality of the discussion that we've had and the report. So Nigel, just over to you for your concluding remarks.
Well, thank you very much indeed, Dan, and thanks for chairing the meeting. And let me add my thanks to everyone who contributed to the report, which I think came together very well, and to the people who did the research for us and so on. And let me just apologise to Bridget, and I think Jack Ashby had written to me to say that you had difficulty getting in to this. So I think some people had difficulty getting in. I hope we didn't turn too many away, but it is recorded, so people will be able to see it later on. The thing that strikes me, as I'm not a mental health professional, is that actually what we're saying goes very much with the grain. It was very striking listening in the witness sessions to people saying broadly similar things about the level of change that is happening and the level of change that is needed to really make a step change in mental health. And the thing that struck me most, and it is in the report, is this idea that professionals, and this is nurses as well as doctors, should be agents of change. There was a Lancet report in 2010 on the health professionals for the 21st century, which really made this point that, you as professionals, you get informative knowledge, that turns you into a specialist. You get the sort of performative knowledge, which turns you into the professional you are by adding your special knowledge to the values of your profession and the way of working of your profession. But you also need transformative skills, and I think this is what Rachel Jenkins was talking about people having the vision, about actually being able to reach out beyond your profession and beyond, in a way, your day-to-day job, to get other people involved. And that's, as Rachel was talking about getting people as active and advocates, and getting your way into the right meetings, and working with these 30 Kenyan groups, or whichever ones you can reach to. So all that kind of stuff. But it's also about just helping people like me who may have caring responsibilities. I don't do caring responsibilities I have as a member of the mental health workforce. I do it from love and family reasons. And there are, you know, that's where most care is actually provided, isn't it? So reaching out and supporting people like me and others, in terms of how you do that, and in the workplace and so on. So I think this notion of agents of change is really a very powerful one. And I think if we can get that into the mental health curricula or education, and it is nurses as well as doctors, this is, and indeed other professionals as well. The other final point that I just want to make is what we're going to do from here forward. So Dan and I are indeed representatives of each of the two houses of the UK Parliament. And what we normally do with these reports, and we'll do with this, and I think it was Sue Baker who was asking how we're disseminating it, is that we will try to have meeting with ministers and press these points. But actually press these points with ministers in the UK about health care in the UK, mental health in the UK, but actually if we can get into the Foreign Commonwealth and Development Office, as I believe it's now called, to be thinking about their development policy, because the UK still has massive influence. We say in the report that we deplore the cut that's been made in the allocation by £4 billion. There's still a big number to play with, of course, and in due course that cut may be reversed. But you know, with that's where we want to influence. So we'll be influencing that. But what I hope other people will do is, we're a small group, is of course use this report in any way you can to influence others. And I hope this is where Sarah Klein's campaign, whose name I always slightly forget. Sarah, do you want to just turn your mic on for a moment? Just name your campaign.
Yes, so the organisation is called United for Global Mental Health. And then we also run a network called the Global Mental Health Action Network that now has 1,300 members from 115 countries. So as a starting point, we'll make sure that that network has received the report. Thank you.
Yeah, so United for Global Mental Health, remember that if you're not already involved, because actually this is a big advocacy job. There's an awfully large gap that we've got to go from here. So those would be just my final remarks, Dan, about thinking about how we really focus on helping health workers to become agents of change, or health professionals to become agents of change, so that we liberate and support all that talent and all that effort and all that passion that is out there, but also how we can get this into the heads of people in government or people in authority, wherever that is, whether it's a town in Kenya or a country in Asia. And that's what we need to do. So my final thoughts there, Dan. So I think we're ending slightly early. I don't see any other hands up. So I guess, Dan, do we call the meeting closed at this point? And if people want copies of the report, they can get it from our website. And can I just turn to Nicole, who I should also thank for making this happen and for supporting the report. Nicole, would you just remind us of the email of our website?
Yeah, I'll put it's Global Health in Parliament. I'll put the link in here, and just to let you know also, everyone who's registered for the meeting now has already received, or should have already received, the report. I've sent that in the meantime. Yeah,
good. Well, please help us disseminate it as much as we can. And that's my response to Sue Baker, I think it was, who raised that question, and indeed others. So on that note, thank you all very much.
Thank you. Lovely to see you.
Thank you. Great.